So traditionally, we think of therapeutic ultrasound for cancer as a tumor ablative or drug delivery system. In our lab, we propose using therapeutic ultrasound as an immune priming agent. So this would be a non-ablative ultrasound that has mechanical and or thermal effects, increasing the tissue temperature less than 10 degrees Celsius. There will be immunological consequences. As Dr. Terhar mentioned, there will be translocation of endoplasmic reticulum chaperones, such as calreticulin, to the cell surface, and this would act as a receptor for dendritic cell engulfment. We would also see an increased release of danger-associated molecular patterns, DAMPs, which trigger dendritic cell activation, and an increased expression of molecular chaperones GRP78. So for this, we use something we call LOFU, or low-intensity focused ultrasound. And for these treatments, we use the Philips TIPS system, the therapy and imaging probe system, where we use a frequency of 1 megahertz at a power of 3 to 5 watts for a 100% duty cycle and a treatment time of 1.5 seconds per focal region. And so here's a schematic of what we propose is happening. So when we do LOFU of the tumor cells, calreticulin gets exposed on the cell surface and acts as an eat me signal for dendritic cells, promoting phagocytosis. HSP70 and HMGB1 act as danger signals, promoting dendritic cell activation, and those activated dendritic cells activate T cells, causing their proliferation and immunogenic cell or cytotoxic cell death. So for our in vitro treatments, we do see an increase in surface calreticulin as well as intracellular HSP70 on 3 different cell lines, a pancreatic, a prostate, and a mouse lymphoma model. And so on the left, you can see our flow cytometry plots of surface calreticulin. As early as 6 hours after treatment, we see an upregulation of that signal. And that signal is maintained up to 2 days after treatment. Additionally, in the same 3 cell lines, we do see an increase in intracellular heat shock proteins, again as early as 6 hours in 2 of the cell lines, and that's maintained up to 48 hours. If we look at 2 different cell lines, mouse Lewis lung carcinoma, 3LL, as well as mouse breast cancer, 4T1, here we're looking at 2 different ultrasound powers, 3 watts shown in red and 5 watts shown in green. And you can see that the 2 cell lines respond differently to the treatments. 4T1 seems to have a power-dependent increase in the surface expression of these 3 molecules, HSP70, calreticulin, and GRP78, whereas 3LL does have an increase in the surface localization of these proteins, but it does not seem to be power-dependent. Additionally, with this increased power, we still don't see a significant amount of cell death. With 4T1, we see upwards of 20% cell death, not significant enough to control the primary tumor. And this upregulation of these molecular chaperones is great, but we need to activate the immune system. So if we co-culture those LOFU-treated tumor cells with dendritic cells, we do see an increase in phagocytosis. So if you draw your attention to the boxed region, those are our dendritic cells that have phagocytosed fluorescently labeled tumor cells. And you can see that after 3 watts of LOFU treatment, there is an increase in the percent of cells that are expressing both the tumor fluorescently labeled as well as the dendritic cell markers. So if we move to our in vivo treatment, our schematic is when we implant the tumors, once they're palpable, varies, but about day 18. We do 3 consecutive days of treatment. And for this study, we did ablation with radiotherapy. And the combination therapy, we perform LOFU about 2 hours before radiotherapy. And we're using a B16 melanoma model. So you can see here, this is our non-treated tumor, and it grows unchecked. The mice need to be euthanized within a month. If we do our LOFU treatment at 3 watts, we see that the 2 growth curves do overlap, indicating that LOFU does not have any effect on primary tumor cell death. If If we do image-guided radiotherapy at 3 × 10 gray, we do see some tumor growth delay, but after about a month, there is primary tumor regrowth. If we combine both treatments, we see sustained primary tumor growth retardation up to 2 months after treatment. If we perform these studies in immunocompromised athymic nude mice, we see that the effect is eliminated, indicating that this is a T-cell mediated response. Additionally, B16 is a metastatic model. If we look at the lung metastases after treatment, we can see that in the combination therapy group, we see a reduction in lung mets. These lungs look quite healthy compared to the other 3 groups where the lungs are riddled with mets. So in conclusion, we can say that LOFU can be used as an in situ tumor vaccination, and LOFU treatment induces a stress response of the tumor cells, and treatment prior to radiation therapy produces a long-lasting primary tumor growth control as well as a reduction in metastases, which seems to be T-cell mediated. I'd like to thank you for your attention as well as the other members of my lab and our funding.